want to talk about Today we want to talk about tobacco use disorder as it pertains to moving the needle forward to success. And I think if you have been with us the last several weeks, you have already heard the theme that we have, which we really do feel is evidence-based, and that is that success is indeed a reasonable goal, and that success can make all of this so very worthwhile. So let's go back a little bit and just do a little brief synopsis here. The comprehensive tobacco screening that we've talked about is the ask. And it's so important not to just do yes or no about whether you use tobacco or you don't, because you don't get the information that you can use later to effectively choose individual treatments. So after you do the ask, after you get the information about past quit attempts and all the different tobacco products or alternative products that we've talked about that perhaps they're using, then you effectively advise them with a personal quit message focused on their issues, whatever that might be, whether it's a wedding coming up or a grandbaby at home, or whatever it is with their medical conditions.
Their personal medical conditions, their COPD, their heart disease, whatever it is, that you want to personalize
that can motivate them. And then you try to measure and identify their willingness to quit. This deal is on them. It is their willingness. It's not your willingness. And you have to allow them to choose a quit date. It's not up to us to say next Wednesday, I really want you to stop and I want you to start this process. You can't do it. They have to say, maybe in the next couple of weeks I can do that. And then you can help them move forward towards that plan. Then you assist. And that's what we want to spend some time on today, with talking a little bit more about how we can assist. What can we do to support them, to encourage them? And it is not just one thing. I can't tell you how often Glenn and I have heard from clinicians, oh, I write everybody a varenicline prescription. And as lovely as that is, and it's an effective drug and it can be used very helpfully, it's not the answer for everyone, nor is it appropriate on its own. It is more appropriate to use behavioral treatment as well as pharmacologic treatment. The combination makes the difference. The combination is the evidence base. It has been proven.
And it's important just to emphasize and drive home this point that getting people to stop using tobacco requires both dealing with the physiologic side of nicotine withdrawal and the behavioral side, that this is a habit that is part of their lives. And if you don't work on both parts, getting people to stop using tobacco is incredibly difficult.
This is a chronic relapsing condition. So the roadmap for success. Today, we want to talk a little bit about the prescription medicines. There are over-the-counter medicines. As I mentioned, varenicline, bupropion, and nicotine replacement therapy are all good choices, depending on the person and the needs, with that behavioral support. And always with follow-up, always. And if this means that your first conversation is about the quit and you don't have time to do that full conversation of how you want to help support them, invite them back, have a specific appointment for this topic. And we're going to talk about the team aspect of this, how important the clinical team is. Developing a clinical team, even if you're a one-person office, you can have a team in the community that can help you. So with prescription medicines, if you, as we've said before, if you offer them without the other support, then you really miss the boat. And we have data, there are numerous studies, but the Mayo Clinic proceedings in 2014 published the first data that showed that when nicotine replacement therapy without any help from anybody else, when the person walks into the Walmart, buys the NRT, takes it home without having a healthcare professional help them to be effective in its use, they will not succeed. And they don't succeed even more than if they did nothing at all to try to stop. And that's what's so significant. We really need to give them the tools. So the importance of the healthcare professional as a piece of this evidence-based strategy cannot be underestimated. Only 1 out of 4 smokers ever even attempt to use an evidence-based strategy or method when they quit.
And I just want to emphasize, when we talk about evidence-based strategy, that is the combination of behavioral therapies along with pharmacologic therapies.
With the healthcare professional involved to support.
And, we'll just reemphasize that at least 2/3 of smokers want to quit. So this is not just us pushing this on people. They do want to quit. The average number of unsuccessful attempts at quitting is at least 6. And most of us think that number is probably more like 12. And a big part of that is that the unsuccessful attempts are done because they have not used evidence-based treatment. They've not had the support, the behavioral therapy combined with appropriate pharmacologic therapy.
And we really have to remember that those unsuccessful attempts are really gold to us. It gives us the way that we can move forward with that individual treatment for the patient. What didn't work before can be adjusted, and it can be very effectively adjusted. So what needs to be addressed? Well, the patient needs support. We keep saying support, support, support. Crucial. Encouragement. Just commonsensical talking with the patient. We want to understand, why did they start smoking? What was it? And what is it in their lives that perhaps needs to be rethought? Is it that they smoke when they are enjoying friendship with a group of people at the bar? Is it that they are enjoying the afterglow of sex? Is it that they drive to work and they don't have anything else that they're doing, so they smoke? I mean, what is it? We need to figure that out. Then we need to be able to measure that level of nicotine dependence. And that can be sort of averaged out. What we want to know is, if they are highly nicotine dependent, are we able to give them enough support with pharmacologic treatment along with the behavioral treatment in order to get them through this very difficult next 3 months to 6 months?
So again, I'm just going to emphasize things we've talked about before. When we talk about nicotine dependence, we want to know when they're smoking that first cigarette in the morning and how many cigarettes they smoke during the day. If you just get those 2 key bits of information, you can certainly know whether someone is highly dependent or is less dependent.
And remember that if it's e-cigarettes they're using, that if they're using a whole pod, that could be a full pack of cigarettes. So we have to really understand, how can we compare these things and be able to give an idea in our head about how needy that person is with their nicotine addiction. We hate to use the word addiction, the dependence. So it's that partnership. We're going to encourage them and be ready to talk about ideas for if and when, it's not really if, it's when they have setbacks. Setbacks might include things like gaining weight or a relapse. These are usual things. These are not you're a bad person things. These are things that will happen, and we need to address them and make that person feel like they have some strategies for during that time when it does happen. I want to hone in on the idea of the team again. We have nurse practitioners with us. We have licensed abuse counselors with us. We have social workers with us. These people make a huge difference in this whole total approach. The medical assistant, when she does that first input to try to help her understand what questions should she be asking, what should she move towards when the patient says, oh yeah, I like to do e-cigarettes, or I've been chewing some tobacco and, it's really been a good thing for me. Help the medical assistant be prepared to ask the important questions, not just yes or no. The pharmacist down the street, if the pharmacist is not in your clinic and they're down the street, have them get involved. They're there for support. In Ohio, we are able to do all kinds of consulting agreements. This is a great value. The more people that attach to that patient, the better the opportunity for success.
And again, we just need to emphasize this is a team process, and it works much better with teams. And there's good data to show the more people who are involved with the team, the better the likelihood of successful quitting.
Another key point is that it's true that combination pharmacologic treatment is the most effective approach for most people. So we need to be flexible and be able to design a plan where that person has adequate coverage. And we're going to talk a little bit today about what that means, adequate coverage with nicotine withdrawal, etc. And this is not a 4 to 6 week process. This is at its best 3 to 6 months many times, and even longer. So we have to really gear in the expectation that this is not a quick kind of thing, and that we are here for the duration. So there's no silver bullet. We need to give high enough dosing to cover that nicotine withdrawal and then to sustain the person for the quit. Now, through this process, you will see that person back, or the pharmacist may see the person back. And it's very important that we just get ready to adjust as we move forward.
So just as a guideline, as a rule of thumb, think about each cigarette as being 1 milligram of nicotine. And so when you're prescribing nicotine replacement, you want to cover at least that much. So if someone's smoking a pack a day, you want to use at least a 21 milligram patch for nicotine. If you use less than that, they are going to have nicotine withdrawal. So you want to use the appropriate doses, and you want to use enough to cover, to try to reduce their withdrawal.
And with NRT, we're seeing that combination products are really the key. So that means the long-term patch might be very effective if a short-term product is provided also. And it would be a short-term product prescribed, dosed at a certain time during the day, so that the person doesn't have a gap in their nicotine in their ability to get the nicotine throughout the day in their steady state.
You don't want people going through withdrawal. I mean, that's really the key. And so you also, if you can, if you know that there are specific times when there are cravings, if you can use your short term to block those cravings. So if somebody always smokes when they're in the car, great time to start using the gum before they get in the car.
So the long-term product would be something like the patch, and the short-term products would be either the lozenges or the gums. And there are a couple strengths of each of those. So there's a 4 milligram and a 2 milligram of the gum and the lozenge. And what you want to do is try to use the higher dose first. The first 4 weeks is when we're going to have the hardest challenge with withdrawal. When we use bupropion or varenicline, both of those work differently than the NRT. And both of those need to be on board and ready to go when the person quits. So we always have a 1 to 2 week starting taper up of either one of those. And they work differently than one another, but both in that tapered way need to be at steady state when the person begins to quit. There are some issues with both of those that we need to make sure the patient is prepared for. Things like insomnia, very, very common. Headache, especially with the bupropion, is very common. Nightmares is an issue with varenicline. We need to help them understand what to do with those side effects, how to handle those side effects. And even with NRT patches, there are times when people have insomnia. With the patch, what we want to do if someone's having insomnia is we want to try to take the patch actually off at bedtime. So these are little key things, but very important for how you tweak all of these different topics.
And it's why we start at low dose with things like varenicline or even with bupropion and increase our doses over time for tolerability. Nicotine withdrawal is like any drug withdrawal, it's miserable. And patients will get lots of symptoms, typically starting within hours. They will have irritability, frustration, and anger. That can go on for as long as a month. Anxiety is very common, again, lasting for weeks. Sometimes people will complain about difficulty concentrating. That's a much more short-term issue with some agitation, difficulty concentrating. That can last for weeks, but usually that's a couple of days. The increased appetite can be a long-term issue, and people will frequently gain weight when they quit smoking.
What can we do for that? Let's talk a little bit about that, because this is a problem of virtually every single person. So what we want to try to do is help them choose snacks that are more healthy, help them to use their habits and their triggers as the opportunity to eat healthy. So for example, we know that folks really miss terribly the idea of having something in their hand, holding something. So instead of holding a cigarette, they can hold a carrot, or they can hold a cinnamon toothpick, or they can hold a straw. Any of those kinds of things can make a big difference. The carrots, they can eat the carrots too. They can do all of the different kinds of things that are focused more on healthy behaviors. That doesn't mean they're not going to gain weight. They're not going to have an increase in their appetite, but justifying it, helping them know that if you gain a little bit of weight, we can deal with that. But the gain of the weight is far less severe to your health if it's only a few pounds than continuing tobacco use.
And I'll also make the point, when they quit smoking, they are changing their health habits. Good time also to encourage people to exercise. One of the things that they can do to help them not want to smoke is to get out and walk. So if they typically smoke after a meal, instead of smoking, walk around the block. That will help with weight and with the smoking cessation. So you can change some of those undesirable behaviors to more desirable behaviors.
And remember that the craving that we see with nicotine is often short-lived. It's the 15 or 20 minutes that they are going to really feel that craving, that you really need to help them identify and help them have ready to go solutions, like the walk after dinner, doing something different, changing their habit. Even little things can make such a big difference for them. We're not here today to talk about all the drug interactions and all of that. And I know I have colleagues in the audience there that are quite capable of discussing these issues at length. However, what is important is that nicotine and drug interactions with tobacco smoke are extremely significant. So nicotine drug interactions, as well as drug interactions with tobacco smoke, you must adjust for the quit. So what that means is that if someone is on proprietary medicine that might potentially be changed by the idea that someone is quitting, the idea that you watch how they are doing and that you adjust down or up accordingly on their regular medicines or on things that are intermittent in their armamentarium.
The one that you really should be alert to, because most patients are using it, is caffeine. And if you discontinue smoking, your caffeine levels will go up by about 50%. So some of this agitation and restlessness and insomnia that people get from discontinuing smoking may be related to a 50% bump up in their caffeine level. So you do want to get people to reduce their caffeine use when they quit smoking.
And remember, they may even just take more caffeine as a response. So they may increase their caffeine just by the fact that they're quitting. So that's a very significant issue. And remember also that nicotine replacement therapy should be very carefully used if someone has a history of an MI, perhaps not choosing that if they have just had a heart problem or arrhythmia issue. And we must be appreciative of that, just as we need to be appreciative of bupropion and varenicline and alcohol. As you know, many smokers also drink. And so that really makes some of these drugs a challenge, and we have to really be appreciative of that. So we're talking about support today. What are some other things that we can do? And this is the commonsensical conversation that you're going to have with your patients. They need to put away their ashtrays, put away their lighters, wash the bedroom curtains, wash the comforter in the bedroom.
Get rid of the smell of cigarette smoke. So it may mean that you've got to clean out your car if you smoke in your car. You want to get rid of the triggers, the behavioral stimuli. So you want to put away the matches, put away the cigarettes, put away the ashtrays, any of the things that create that response. This is when I smoke. If you always smoke right after breakfast, do something different with breakfast.
And I think these are things that if you're dealing at all with other substances that are issues of dependence, these are similar sorts of things, trying to give people alternatives. Something in the hand. I have patients who have taken up knitting because they're doing something different now with their hands. So that's great. If they can do that, that's a great solution, or even part of a solution to help them stay busy. If they have a real focus on March Madness and they enjoy the company of socializing with their friends, that's a big challenge when all their friends are smoking and partying and doing everything, and you really want to watch March Madness. You have to help them know that it's okay this time, this year, to watch March Madness with someone else, on their own, whatever. And yes, they may have to adjust the socialization aspect. If their spouse is a smoker and doesn't want them to quit,
That's a challenge.
huge. Okay. So have them find another friend, have them find somebody in your team that they might be able to connect to. Maybe the pharmacist, maybe the nurse practitioner, whatever. Some of these things that can help them through that very difficult time. It can make a big difference. As Glenn said, relaxation exercises, other exercises, walking is just so easy and important if people can do it.
One more simple, and oftentimes it can be simple things that don't cost money. If somebody smokes in their car driving to work every day, recommend they take a different route to work so that they have to be concentrating on different roads to take. Simple things like that. They don't cost any more, but it can get people into a new routine, get them away from their regular cigarette smoking approach, giving them something else to concentrate on.
So the brief clinical interventions, we've talked about how important it is to have your team document. We have to have documentation. If you do not document, you cannot bill, and you have to document specific issues. So please make sure you're doing that. The MA can be doing that. The nurse can be doing that. You can do that. There are billing codes for symptomatic versus asymptomatic tobacco issues, brief versus intensive. We talked a little bit about that previously. This is based on time. So brief is 3 to 10 minutes of your time, and intensive would be greater than 10 minutes. So today we've talked about all the 5 A's. We've gone through that. We were not able in our 3 sessions to get down to every individual aspect of tweaking the medications, etc. But I think that you have a good handle for what you need to do. And we can always come back if you'd like us to and go more specifically into each of those medications. We really didn't give all of them due justice.
There we go. And there are good references. There's a good reference slide at the end of our first presentation that you all should have. So again, you can get more detail as you want it. One of the things that we should just talk about is who doesn't get drug therapy for tobacco cessation. People who smoke less than 10 cigarettes per day generally are not treated with pharmacologic approaches. We don't want to use medications in pregnant women if it's at all possible. And there's no good data on people under the age of 18. And again, we try to avoid medications in that group.
And again, we've talked a little bit about how this is a disease of young people. We've got to do the preventive things, which don't really end up always in your offices, but preventing access, a huge challenge because of the internet and because people who want the products are very ingenious. They are much less likely to quit until they're in their late 20s. And I know we have a pediatrician in the office, or in the office, we have a pediatrician, and we have a pediatrician in the audience today. And I know she's been with us the last week or so, and I appreciate that. This is a real challenge for pediatricians because they can't always depend on the medications or a young person who says, oh, I'm ready to quit. Here are the medications. Some of these are the inhaler, the nasal spray. Those are prescription products. We've talked about the bupropion SR. That would be the product that we would recommend in the bupropion category, and the varenicline. Oops. Again, let's go through the nicotine gum, because this or the lozenge is probably the most difficult to explain to people, that there's a peppery taste. So when you get that peppery taste, you stop chewing, you park it into the cheek, and that's true with the lozenge. You put it in your cheek. You do not leave it in the main area on your tongue. We don't want people to swallow the liquid. We don't want any part of that.
Nicotine makes you sick to your stomach.
That will cause nausea and problems. So what we want them to do is park it. Usually we do that for about 30 minutes until the peppery taste is totally out. So we chew, park, chew, then spit it out. Okay. We've talked about these. So here is just a question for the group. Appropriate counseling for a patient using gum would include which of the following? Do you chew it continuously? Do you eat and drink normally? Let's talk a little bit about that. We don't want patients to eat or drink during the gum chewing. In fact, 15 minutes prior to using the gum, we should not be eating or drinking, and especially acidic kinds of products. So that's a really key point, that you do not want the patient to use the gum during the time that they are going to have their lunch or their dinner or drink a soda. Okay.
Because the acidic environment increases the absorption of nicotine. So you really don't want to adjust the pH when you're using this.
And it is not a product that should be used just for cravings. In fact, it should be prescribed, or it should be used in a cyclic manner every 1 to 2 hours. So when we have the patch on board already, we've got that going, still use some of the gum every couple of hours, and that gives that patient coverage. And so they may use the gum 9 times during the day, and that's okay. And early on, that's really good, because that gives them the chance to cover some of those nicotine withdrawal aspects that are acute at that time. Okay, very important. Let's talk a little bit while we're doing this. Let's talk a little bit about the patch. We talked about the fact that people may have a problem with insomnia, and that they could remove the patch at bedtime and then replace it in the morning. That's okay. But if they are, I think I often use the concept construction worker, or they're outdoors, or they're in a place where they might sweat. Maybe they're a personal trainer and they might sweat during the day. They may not do well with the patch. The patch has to stick on. It has to stay on. So if they're sweating up a storm, that is not going to be an adequate choice for them. And you need to rethink that, the long-term product accordingly. And perhaps they can use an inhaler. Perhaps they could use a spray instead. Okay.
A couple of other things about the patches. They should not cut them. They don't work well if you cut them. You don't get your normal amount of absorption. They should change the site every time they put a new patch on, because you can get skin irritation from the patch. They need to always wash their hands after they've applied a patch. They really should follow the advice, the instructions on patch use.
Yeah, that's good advice. And here's another question. When we talk about bupropion and varenicline, we've mentioned already that they really should try to take that a week or two prior to the quit date. Very, very important. Do not start it on your quit date. It does not work. It will be ineffective. They will be frustrated. They will have a relapse or 10 relapses. Okay. Do not start it after the quit date. That doesn't work.
But let me make just one point. Some patients will get motivated and they'll start their varenicline or they'll start their bupropion and they'll want to start reducing their cigarette use. Or they may have a decrease in cravings related to being on the drug. Either way, they may start reducing their cigarette use even before their quit date. That's great. We don't want to discourage people from reducing their cigarette use, but you do want to set that quit date 1 to 2 weeks after they start the drug. And if they are ahead of the game and want to reduce their cigarette use in that 1 or 2 weeks, you never want to say no to that.
So they start their patch and then they relapse and they don't even want to come in to see you because they relapse. They're so embarrassed because, as you and I know, it's an awful thing to relapse, isn't it? But you know what? It's a usual thing. And we need to reinforce that it is okay to relapse. What isn't okay is relapsing and giving up or relapsing and stopping your medicine. No.
And I think we should be careful to distinguish between slipping up and relapsing. Patients are going to occasionally sneak another cigarette. They're going to be in an environment where they're stressed, or they're with their friends, or they're in some situation where they're going to have a cigarette. And that's a slip, and you don't want them to do that, but it's okay. You forgive them, go on. What you don't want is for that slip to lead to them going back to smoking and what we would call a relapse. So you want to be straight with people up front. An occasional slip, we're going to live with that. That's okay. That's part of life. There's no punishment that goes with that. You don't have to feel real guilty about it. If you can just take that one cigarette and get back to your cessation, that's still a big win.
You know, I know we have nurse practitioners in the audience. You know, this is a wonderful place for nurse practitioners, if you can do it, to do things like have a group class, offer a group class where people can come and talk with one another and see sort of a little checkup in between the clinical visits. It really can make a big difference. People in this situation do very well with group therapy. They really get helped by hearing that somebody else has had a certain challenge. So using that can make a big difference too. So we've talked about just about anything you can think of, jargon and trying to be non-judgmental, trying the 5 A's. We didn't really spend any time on the quit line. Over the years, the quit lines in each state have been handled very differently. In Ohio, for years, up to very recently, it was not available for free for everyone. It is now available for free. So 1-800-QUIT-NOW is an option. It should not be used alone. I have to stress that. The idea, hopefully today with moving the needle, is that the clinician needs to be involved. The team is critically important to the evidence-based approach. So giving the person a discussion, getting them sort of started and handing them the 1-800 number, good luck, is not a good approach. It will not help them as much as you supporting them through them using the quit line?
Right, the quit line is a good part of your team, but it should not be a use alone approach. Great, somebody's got an issue in the evening, at night, you know, that's somebody that they can talk to help them through the situation. You want them as part of the team, but they can't be the whole team.
Depending on the insurer or depending on their situation, even the quit line can get them free NRT for a certain period of time. That is very important for you to know what the resources are in your community for getting them. We would hope in every case that people could get free therapy, free treatment, free pharmacologic support, but it isn't always the case. But they may reduce the price for them, and that can make a big difference.
Just be aware that the dose of the patch, for example, that you get through the quit line may not be optimal for your patient. So you want to know what your level of nicotine dependence, what your preferred dose is, and see if that's the dose that they're getting for free through the quit line.
Yeah,
It's
very
not always,
important.
it's not always the appropriate dosing. So again, those are things you just need to be aware of as you go through it. Free is great, but free
At
in
the
an
wrong
inadequate dose may create another failed quit attempt and may cost you the ability to use the quit line as a way to help get somebody to quit smoking.
Yeah, that's the important aspect of evidence-based treatment. It needs to be individualized. If you don't give them enough support or pharmacologic dosing, they will have more difficulty. Now I think we're done with our slides. What I'd like to do is try to go back to our group and get in a few hopefully helpful questions. I think we had a question from last week, didn't we, Nicole, that we didn't answer?